Okay, well, it looks like it's 9 o'clock, so why don't we go ahead and get started? It's great to see everyone. Thank you for attending this session on cardiovascular and brain health. And my name is Mary Cushman. I am a professor at the Larner College of Medicine at the University of Vermont. And I'm joined by my co-chair, David Edwards from the University of Delaware. And we're going to get right into the session and explain that we got put together to design this session, not knowing each other in advance. And it was great to get to know each other and brainstorm about people that we could engage to speak in this session. So what we've put together is a set of speakers from CoBRE centers across the Northeast that are studying topics related to cardiovascular disease and brain health. And I think we have a great slate of speakers for you. I'm the co-director of the 1-year-old CoBRE in Cardiovascular and Brain Health at the University of Vermont. And David is the director of the University of Delaware Center in Cardiovascular Health. So we found that we had a lot in common, even though I'm a hematologist and he is in a kinesiology department. So it was really kind of cool to get to know each other. At any rate, so why don't we just get right into it? And our first speaker is my co-director of the Vermont Center for Cardiovascular and Brain Health, Dr. Mark Nelson. Dr. Nelson is chair of the pharmacology department at the Larner College of Medicine, and he is a university distinguished professor. He is I would say a luminary in his field. He was recently elected to the National Academy of Sciences, which interestingly enough, he is the first University of Vermont faculty member to be elected to the National Academy, which is an error that requires correction because these things are about achievements, but also about politics. And so for those who are junior in their careers, I never thought a lot about that growing up, but the actual politics of science is important, and it's important to your institution and to your career. So don't forget to pay attention to that and try to take opportunities to get these honorific things. And the National Academy is the height of achievement, and we're so proud of Mark for that. So, so Mark's talk is really captivating. I think you'll enjoy it. The title is, and this is a keynote, so we have 20 minutes. The title is Translating Thought into Blood Flow in the Brain, Capillaries as Sensors of Neural Activity. So I will turn it over to you, Mark, and thank you for being here.
Thanks, Mary. Thanks for the great introduction. Let me see. Can you guys see the screen?
Yes.
It doesn't look like it's, there we go.
Yeah, okay. Well, welcome everybody. I'm not sure I'm sufficiently caffeinated, but I'm working on it. I changed the title a little bit. I'm going to talk about some of our recent work on rescuing blood flow in the brain in Alzheimer's and small vessel disease. And this serves just as a simulation of neural activity in the brain. A little bit of background about small vessel disease. This is a simulation of neural activity in the brain. And as you all know, when neurons are active, they need blood delivered precisely and rapidly to active neurons to nourish them. And this goes on in your brain moment to moment, day in, day out for years before things go wrong. But small vessel disease is a major cause of stroke and dementia. In many of the cases of Alzheimer's and small vessel disease, impaired brain blood flow precedes overt clinical symptoms. There's no therapy at the moment yet. So therapeutic approaches are needed. And I'm going to provide evidence for one possible therapeutic approach, and that involves a lipid PIP2 as a therapeutic solution to restore normal blood flow in the brain. And so sort of take-home messages, the lipid is phosphatidylinositol 4,5-bisphosphate. It is, well, I'll show you is it therapeutic agents, an endogenous lipid that enhances blood flow. It's an essential cofactor for brain blood vessels to sense neural activity, and it's required for the activity of a particular potassium channel that's instrumental in controlling blood flow in capillary endothelial cells. So that's the idea. A little bit about the ion channel. This is the crystal structure of the inward rectifier potassium channel. And as you can see here, PIP2 and the inner leaflet of the bilayer of the cell plasma membrane binds to the ion channel and then puts it in a state where it functions. So without PIP2, it doesn't function. And what I'm going to show you is that small vessel disease in Alzheimer's mouse models this system is crippled, and these ion channels aren't functioning because of a lack of PIP2. It's a minority phospholipid on the inner leaflet of the plasma membrane, and it's crucial for the activity of a number of processes, including this ion channel. So here's sort of the basic take-home message. Normal brain activity sends a signal to the blood vessels to deliver blood to the active neurons. And in many diseases, this is crippled early on in the disease process. Of course, I was going to shown here. And what I'll show you is that a couple of examples where this is crippled in small vessel disease and in Alzheimer's. And I'm going to show you that PIP2 reverses the decline in blood flow, and so we return to a normal state of blood flow. And so, so a little bit of background. I studied neuroscience long ago, and in neuroscience we never mentioned blood vessels, but a human brain has about 1,000 miles of blood vessels. The smallest blood vessel and the majority blood vessel are the capillaries, which the capillary touches basically is in contact with every neuron. So our data suggests that the capillaries are in fact the sensors of neural activity, and I'll show you the mechanism, how we think it works. And put in perspective, the width of a capillary is about 1/20 the width of a human hair. And the lumen is about 4 microns in diameter. A red blood cell is about 6 microns in diameter and sort of wiggles its way through a capillary. At these dimensions, a mouse capillaries and human capillaries and red blood cells are the same dimensions with the same requirements for delivering oxygen and glucose. And what I'm just going to show you some previous evidence that capillaries sense neural activity to send electrical signals upstream against the blood flow to tell upstream arteries to dilate. So imagine that this vascular cask, all the capillaries are made up of a single type of cell called an endothelial cell, and endothelial cells line every blood vessel in your body. So you have about 10 trillion endothelial cells in your body, making about 2% of your body mass. And they're all coupled by proteins called connexins, gap junctions. So they're all electrically coupled. So now imagine this is really electrical circuit within your brain that can send signals, electrical signals upstream to tell upstream arteries and arterioles to dilate to deliver blood downstream. And this just shows a little bit of background. This was first described in the 19th century by Roy and Sherrington and others. But this shows an example of neural activity, in this case in a mouse, wiggling the whiskers of a mouse, neural activity in the somatosensory cortex, and then blood flow goes up rapidly and precisely in response. This is also the basis of functional MRI, which was used to map neural activity in animals and in humans, with the assumption that anytime a neuron is active, blood flow is going up in that part of the brain. Well, that may not be true, and but this is how we interpret neural activity. So the puzzle is, in what way can the capillaries be excited, chemical, electrical, or mechanical? And I'll show you some of the electrical signaling that's at the core of this of the process. And also, by the way, the process of activity-induced increases in blood flow is called functional hyperemia. The neurons are active, they're functional, increase emia, blood, increase in blood flow. And this was described in a Nobel laureate speech by August Crowe, a Danish physiologist, about 100 years ago. So this is the basic scheme. This would be down in the brain, is the capillary endothelial cells. And then active neurons release potassium during every action potential. This accumulates around the capillaries, which are adjacent to every neuron. This activates a particular potassium channel from the outside called the rectifier, strong rectifier potassium channel. And we've actually deleted this one specifically from endothelial cells. It's a KR 2.1 for what it's worth. This activates the ion channel. It sends a signal from cell to cell, going upstream to the upstream penetrating arterioles, then through another gap junction into the smooth muscle cells to cause vasodilation to deliver blood. So this really satisfies all the requirements. It's fast. It happens at the site of neural activity. It sends signals at several millimeters a second upstream to tell the penetrating arterioles to dilate to deliver blood. And for all you neurobiologists out there, you might view this as like, if you've studied action potentials, this is a depolarization, repolarization. This happens in neurons, cardiac muscle, skeletal muscle. Endothelial cells, unlike neurons, have rather positive membrane potentials. So this is a negative signal. So it's like an inverted action potential. And this potassium channel has also unique properties that it's activated by hyperpolarization and by external potassium. So this actually shows just a cartoon of the sort of the concept. Potassium goes up during neural activity, sends a retrograde signal, tells the upstream arteries to dilate to deliver blood. So then what goes wrong? So a little bit background on small vessel disease. It's the leading cause of age-related cognitive decline, responsible for a substantial fraction of dementia cases. They're also intracerebral small vessel disease, and these are deep bleeds that are really devastating. And we also look at this, and it's also is responsible for a large fraction of ischemic stroke. We study one particular, I've studied several actually, but one that we study quite a bit is called CADASIL, cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, CADASIL. This is the most common monogenic cause of small vessel disease. It's an autosomal dominant mutation of the Notch3 gene that's only in smooth muscle cells and pericytes in the brain. The frequency is about 1 in 50,000, so it's rare, but not that rare. We've had several international consortiums, one on this topic, one supported by the Foundation Leduc. This is my European director, Anne Joutel, and Martin Dischans, head of the Stroke and Dementia Institute in Munich. We also have a European Union grant on the same topic. We're now in the last year. You can see some of the same players. There's Anne Joutel. There's Nick, Messiah from the lab. Messiah and Nick have done a lot in this work. This is in Paris pre-pandemic. Last year we were supposed to go to Utrecht. We didn't go anywhere. We had it online, which is definitely a drag. So we're supposed to go to Munich for our last meeting in October. We'll see. So we just had 2 papers on this. And one, I'll just show you here, showing that PIP2 rescues cerebral blood flow in small vessel disease, in particular in CADASIL, by activating the capillary inward rectifier potassium channels. There was also a commentary on it in the proceedings of the National Academy of Sciences. And this just, one of the preps we use, and this will illustrate the power of PIP2 to restore normal vasodilation, is a preparation where the arteriole from off the middle cerebral artery within the brain is cannulated, pressurized, which causes it to constrict, and the capillaries are left intact, shown here in green with lectin staining, and the red is smooth muscle alpha actin expression in the smooth muscle cells. So we then, with this prep, we can stimulate the ends of the capillary and then look at upstream dilation or other events. Fabrice in the lab developed it. I wanted to call it La Fabrice because he's French, and Nature Neuroscience didn't go for that. So too bad. So this shows an example of this. I should say we do experiments from single cell molecular electrophysiology, this isolated ex vivo prep, and in vivo. So this shows a process, spritz on slightly elevated potassium, 10 millimolar, and then look at the upstream dilation. You'll be able to see it here. live. So notice that these arterioles are 15 microns in diameter. And there, potassium goes onto the capillary, and then a millimeter away, we measure the dilation of the arteriole, upstream arteriole, and you can see it dilates. This is actually a maximum dilation. Remove the stimulation and returns. So we've done this in vivo, ex vivo, and in the disease models. So here's the basic idea that that loss of PIP2 suppresses this whole system, and these channels don't work. So this shows the same experiment, but from a caddisol brain, mouse brain. And note, now we stimulate the capillaries. Remember the last movie, no effect. Now we put the pipette on the arteriole directly here, and we get a large dilation for direct application. So this is from a caddisol mouse brain, and now we add PIP2 to the bath. Within 15 minutes, we restore the normal dilation. I mean, this is pretty remarkable. And if we add PIP2 in vivo to the mouse brain, we restore the increase in blood flow to normal. So this is, Amreen and Osama, I should say, Osama Haras is one of our project directors of the COBRA. Amreen's in the pipeline, and Albert actually moved to Nevada and is another COBRA. So we also looked at an Alzheimer's mouse model and looked at the same process. And this mouse model also has a deficit in activity-induced increase in blood flow. And so a little bit of background, there's Amreen and Osama. We use a mouse model called the 5XFAD mouse model. I'll show you a little bit about that. And I think you're all aware of it. In Alzheimer's, it's accumulation of amyloid beta plaques, tau protein, neuronal loss, loss of cognitive function, which is the same thing that happens in caddisol. But one of the early deficits is reduced cerebral blood flow and functional hyperemia, activity-induced increase in blood flow. So where is the defect? Well, we found the defect in caddisol resided exclusively in the capillary endothelial cells and the loss of PIP2. So we tested this here by looking at the possibility that functional hyperemia in Alzheimer's also is due to a loss of capillary inward rectifier potassium channels, shown in this cartoon here, where PIP2 is the channels are there, but PIP2 is not there, and the channels are there, but not active. And this shows a sort of lifestyle of, this is a transgenic mouse model that expresses 5 human mutations associated with familial Alzheimer's disease. So they develop plaques early on in life, cognitive impairment, synaptic loss, and by 12 months, neuronal loss. And we use 12-month, these are all sperms of 12-month-old animals. And this shows diving in the brain and standing for amyloid beta plaques. You can see on the right is the Alzheimer's mouse model, on the left is a normal wild type. This shows we had to cover the journal Function, which is a New American Physiological Society journal. And this shows the accumulation of the plaques. And you note that the plaques accumulate all around all the blood vessels. This is pretty characteristic of a lot of Alzheimer's disease. It has a major vascular component. So again, we test this hypothesis. I'm just showing one of the experiments. These are this is then a cranial window above the part of the brain, the barrel cortex, that responds to whisker stimulation. And as you know, whisking is one of the big sensory inputs for rodents. I guess for some men too. Maybe the only sensory input for some men, but nonetheless, we then use laser Doppler fluorometry, so measuring the backscattering of light. This is the same thing, neuronal stimulation, so neurons are firing, blood flow goes up. Same thing, blood flow goes up. So this shows an example from a control mouse. We get the whiskers here, and blood flow goes up by about 23%. In the Alzheimer's mouse model, 1 month old, it goes up by less than half, 11%. And it's shown here in the bar graph. Now, the remarkable feature is this component is all due to the loss of the inward rectifier potassium channel. And we can tell that because we put on barium ions at very low concentrations, and they're rather specific blockers of this potassium channel, and they block the pore from the outside. It works rapidly and reversibly. And what you can see here in the control, about 70% of the increase, 70% of the increase in blood flow is blocked by barium. If you go to the Alzheimer's mouse model, the entire component that's gone is the barium sensitive component. Shown here, barium has no effect in the residual increase in blood flow. So then what we did is then IV apply PIP2 to the animal. Again, I'll show you here. And this just shows, and there's also a literature on aberrant PIP2 metabolism in Alzheimer's, and it's decreased in a whole variety of Alzheimer's from humans to mouse models. And this shows just some of the literature. So we add PIP2, and this shows wait 20 minutes in vivo. It's in the bloodstream, and blood flow is restored to normal, as you can see from the middle trace and from the bar graph as well. So if we add PIP2 to a wild type, it has no effect. So this is basically restoring the same level of increase in blood flow to whisker stimulation or functional hyperemia in about 20 minutes. This is pretty remarkable. So the common features of both the loss of activity-induced blood flow in small vessel disease and in Alzheimer's, they're reduced by about 50–60%, and it's the loss of PIP2, and we can restore it by giving exogenous PIP2. So here's a summary. Normal wild type function. PIP2 is necessary for the channel to function, to send electrical signals, to tell the arteriole to dilate. In Alzheimer's mouse model and small vessel disease, this PIP2 is lost. There's impaired increase in blood flow, and this can be restored by adding PIP2. I should also mention one thing we did in our network is we had a clinical component looking at CADASIL patients and shown that they also, even young people, had a deficit in functional hyperemia, in this case to motor function and to visual cues. So PIP2 restored the function. So sort of this is where we're at, sort of like blue sky thoughts for early Wednesday morning and a gray morning here in Vermont. This is the lab here. I'm leading the charge. I should say it's our COBRA group. Is that me and Mary leading the charge? I think maybe. But the big question here is, what is the consequence of having compromised cerebral blood flow early in life? And if you can restore normal blood flow, will that improve cognitive function later in life? It also points to the key role of PIP2 in capillary endothelial cells in modulating the response to, in this case, neural activity. But I think the same thing would apply to things like in organs like skeletal muscle and cardiac muscle. And then we have a potential druggable target, meaning the capillary PIP2 inward rectifier channel linkage. Or other possibilities would be to give precursors of PIP2, which are shown here, that may lead to the accumulation of PIP2. So I want to acknowledge Mary, and we're off to a great start with the COBRA. This is our new research building. And so we're going to have the top floor here in about a year. So we're really excited about that. We've got great program project directors, and it's been a lot of fun, a lot of work. And I give Mary all the credit for it, because doing this during a pandemic hasn't been easy. A bit of the people. Fabrice did a lot of the original work. He's now at the University of Colorado, tenure track. Osama now is a tenure track faculty member here. That's our lab meeting at Hadrian's Wall and near the Scottish border in February. Beautiful day. Albert and Messiah, or Albert went to Nevada, tenure track. Messiah was another project director. Gro was a Danish postdoc, and there's Fabrice again. And thank you. And I'll stop sharing my screen.
That's amazing, Mark. Thanks so much. So if you have questions, you may type them into the chat box, or you can raise your hand. If you go down to the bottom of your screen where it says reactions, click on that and you can click raise hand and we'll acknowledge you and you can actually speak, which is nice. I hope we can have some interactive conversation. So I will start, Mark, by saying or asking a question just about, I'm a clinician, an epidemiologist.
Oh, you
I'm
are?
still trying to understand all of the science that you do. And my question is there evidence from human populations that brain blood flow, apart from stroke, where you have necrosis of brain from acutely impaired blood flow, that brain blood flow itself relates to cognitive performance? I'm trying to figure out if there is a line of research that has investigated that using imaging techniques or what have you.
Yeah, that's a really good question. I mean, the one thing that's clear in humans is that there is a deficit in both what's called autoregulation, is with blood flow when pressure changes, blood pressure changes, and a deficit in functional hyperemia. The question is associating that with long-term cognitive decline, and then the flip side is if correcting it, would you improve cognitive function? I don't know. That'd be a great thing to look into, Mary, because I don't know. I mean, it's kind of tough because you have to look at over years,
Or even if acute changes could impact, I think it's something I hadn't really thought of listening to you speak before. And it's just a fundamental issue. You can improve brain blood flow, but if the brain is full of, tau and tangles and plaques, would it improve it? Would it improve the situation? Anyway, so I see Denise Peters had her hand up. So Dr. Peters?
Yeah, no, my question was kind of along the similar line as yours, again, coming from a more human research side. You had said, if you see these blood flow restriction changes early in life, maybe we could, address it sooner and prevent some of the stuff. And I was thinking, again, down the road, like, in humans, if the science gets to that point, would this be more of like a preventative approach, or would it be if we start to see these early changes early on, would we hit it sooner, or would there be a threshold that it needs to kind of get to before we kind of came in and did that? So just kind of, if you've thought along those lines, Mark.
Yeah, no, it's a really good question. I haven't we can correct it, but the question is, like, in the Alzheimer's, CADASIL doesn't have neuronal cell death, whereas Alzheimer's does. And if that gets that far, I don't think you could reverse it. But there's another aspect, which one of my colleagues, Micah Niedergaard, looks at, is what she calls glymphatic flow. The CSF, the cerebrospinal fluid, goes down around the blood vessels and is involved in clearing out debris out of the blood vessels. And she has shown that this increases when you sleep. And the tone and these things are intimately linked to changes in blood flow within the blood vessel and the perivascular space. So there could be a combination of both those things in correcting normal blood flow control. But if you look at, Mary, the other thing was, if you look at, well, maybe Dave knows more about exercise physiology. People say that people that do aerobic exercise and they look at blood flow changes in the brain, they're like 10, 15 years younger than a comparable person. And you think of a benefit.
Yeah, so Mark, that Dr. Krasnova has a question in the chat.
Okay.
PIP2 as a druggable target for AD is fascinating. Does increased physical activity or learning new skills have an effect on blood flow in the brain, or PIP2? Do these activities have a protective effect against reduction of blood flow in AD? These sound like future questions, but I think there is some evidence about physical activity and blood flow, as you mentioned.
Yeah, I mean, thanks, Irina. It's great questions. And definitely there's evidence of physical activity and improving cerebral blood flow. What the impact will be on the progression of small vessel disease and/or Alzheimer's is not known at the moment. But I should also say, this is my prop. This is lecithin.
Oh.
And lecithin is made of phospholipids, including phosphatidylinositol, which is the precursor of PIP2. And they advertise over the counter as improving cognitive function. Now look at this. It's empty. And it still hasn't helped me, but I'm still working on it.
I was gonna say, because I do watch a little bit of television in the evening. If you
Yeah.
watch any television, you see Prevagen ads saturating the market. And I'm not sure what's in Prevagen, but it would be nice to know if it really does anything for people.
Yeah.
So maybe it activates PIP2. We'll have to, kind of think about that.
Mary, but Irina, we have patented this approach, and we are now gotten from the university called a Spark grant, Osama and I, to look at developing how long does it matter which PIP2 analog is it? Would a precursor be better? Delivery, and for example, when we inject PIP2 into the bloodstream, how long does the effect last? An hour, a day, a week? And so and part of the LeDuc Foundation, they actually have a venture capital arm called Broadview Ventures. So I'm having a discussion with them next week.
Great.
So
Great.
it's kind of fun.
I won't let you market anything that isn't proven to work though, Mark. All right. So with that, I'm going to turn it over to Dr.
Thanks,
Evans
everyone.
to introduce our next speaker. Thanks, Mark.
Thank you.
Thanks, Mary. Thanks, Mark. That was great. So I will introduce our next speaker, Dr. John Slater. He's from the University of Delaware. His home department is the College of Biomedical Engineering and the College of Engineering. And he's part of our COBRE and Cardiovascular Health at the University of Delaware. He'll be one of our phase 2 project leaders. So the title of his talk is Biofabrication of Microvasculature-on-a-Chip devices to investigate pathological processes. John, why don't you go ahead and share your screen and get started?
Okay, thanks, Dave. All right, good morning, everyone. And thanks, Dave and Mary, for giving me this opportunity to speak. So I'll tell you a little bit about some work we've been doing in the lab on fabrication of microvasculature-on-a-chip to model pathological processes. So really the motivation driving this is that human models are ultimately the best model to use to study pathological and physiological processes, but often we're not able to do that depending on what we want to study. Next level down are large and small animal models, which are extremely useful, but often to measure things temporally or to look at biochemical changes or to have control over the environment is often very difficult. So, the third level down is then in vitro devices where you think of culturing cells and petri dishes or these sorts of things, but they often lack physiological relevance and the behaviors may not be what you would expect in vivo. So I'd say for the last 2 or 3 decades, there's been this push for creating in vitro microphysiological systems out of all human cells that are sort of simplified versions of specific organs in our body to be used for, they're often used for drug studies, as you can see here, but they're being used more and more to understand pathological processes and for drug development. So today I'll focus on how my group has been working on trying to create in vivo vascular architecture embedded inside of these engineered in vitro systems so that we can have physiological flow or pathological flow processes and be able to understand what impacts they have on tissue function. So to kind of get an idea of the length scale, we saw this in the last presentation of, what size do we care about? If we use the heart as an example, you have a large aorta, 2 to 3 centimeters. You have arteries on the order of 3 to 5 millimeters, arterioles in the 100 to 500 micron scale, and then capillaries, which are down to 5 and 20. So my group has mostly been focusing on how can we create simplified arterial structures and then capillary-like beds within these tissue engineered constructs. So to create capillary systems, there are a number of methods available. One of the most common methods used is self-assembly via vasculogenesis. So this is out of Roger Cam's group. What they often do is take endothelial cells and sometimes some support cells, either fibroblasts or smooth muscle cells, trap them in a matrix, and they'll self-assemble into a perfusible network. which is really nice. You often get, these capillary sized structures that look similar to what you would expect in different organs in the body, and they're perfusible, which is really nice. So you can use these for perfusion studies. The second sort of general method is engineered techniques. Rather than having the cells self-assemble, can we guide exactly where the cells go? So here's an example of using a sacrificial bioprinting technique where you can create structures that you like, surround that in a hydrogel. In this case, they have one cell type in green in the surrounding hydrogel, and then human umbilical vein endothelial cells in the actual blood vessels, and you can start to create structures that you want. The problem is the resolution is very limited, often very limited, in this case about 150 microns, and the architectures aren't always what you would expect if you're trying to mimic in vivo architectures. So again, we're really trying to think, how can we span this sort of 3 to 4 or 5 micron range up to this 300 micron range? And again, self-assembly is a great technique for this small scale, biofabrication or microfabrication for this larger scale. But we've been working on a number of techniques in order to be able to span the sort of whole scale in a single tissue, right? So from the 3 to 4 or 5 micron scale for simple structures, are up to the 300 micron scale for arterioles. And then can we start to create systems that mimic the architecture and flow properties of in vivo systems? So I'll give you a little bit of motivation. We're working in a couple of areas applying these, but the motivation I'll use today is the metastatic cascade in cancer. So we specifically focus on breast cancer. So if you think about a primary tumor found in a patient's breast, the cells from this tumor can invade into the surrounding stromal environment. They then intravasate into the blood vessels. So that's shown here. They intravasate through the endothelium, make it into the circulatory system. And now they're known as circulating tumor cells, where they can survive during this blood flow, get to a secondary organ, adhere to the endothelium, transendothelial migrate, right? So migrate out into the surrounding tissue, and then start to form new tumors or not. And there's also this idea of size limitation at the small scale in capillaries. So we've been focusing on my group creating engineered vascular systems to study these processes. And we're really interested in endothelial cell adhesion to, circulating tumor cell adhesion to the endothelium, and also the size limitation. And quite a bit of our work has also been controlling on the fate of these extravasated cells once they make it out into a foreign tissue, and controlling how the extracellular matrix regulates dormancy, death, and the switch from dormancy to proliferation, but I won't discuss that today. So if we focus first on the adhesion part, we're really interested in studying the role of inflammation and why is there a strong correlation between either acute or chronic inflammation and probability of metastasis with many different cancer patients. So the way we think about it, so here we're mimicking the endothelial cells as these little rectangles. Here's a circulating tumor cell. So the circulating tumor cell needs to be able to grab on and arrest itself from flow in order to migrate through the endothelium into the surrounding tissue. So we know from inflammation that during the inflammatory processes, the endothelial cells can express new or increased expression of cell adhesion molecules that may allow the circulating tumor cells to adhere for flow arrest. Their junctions can also be loosened, which could expose the underlying basement membrane and also facilitate circulating tumor cells extravasating. And then associated with this is an increase in permeability, of course, when you have an inflammatory response due to loosening of cell-cell junctions. So we've been creating simple arterial systems that allow us to begin to investigate these processes. So what I'm showing you here is here's sort of an idea of what our chips look like, our early chips. We have collagen or synthetic hydrogels that we form in these wells. We create these simplified arterioles, in this case 200 micron diameter and about 5.5 millimeters long, that span across the system. And then we can have an inlet and an outlet where we can hook up a flow, either using a peristaltic pump or syringe pump or a pressure controller, and be able to control the flow through these sort of simplified blood vessels, if you will. So here you can see endothelial cells lining one of these blood vessels. This is embedded in a collagen matrix. So this is a 3-dimensional structure embedded inside of a surrounding collagen matrix. And you can see that we get cadherin junctions, F-actin, and nuclei. And here's a 3D rendering just showing that this is indeed a cylindrical structure, again, embedded in collagen. So to create these very simple structures, we just simply use a molding technique where we take an acupuncture needle of a desired diameter. We can put that into our system coming in from the side here. We then put in our collagen gel, and then we can remove this needle and backfill with our endothelial cells in order to create our simplified blood vessel system. So this is a really sort of straightforward and easy technique to make these large, simple arterial structures that we can expose them to flow. So here's a little bit of characterization to sort of indicate to us whether our microvessels are behaving as they should or not. So we seed our endothelial cells for 2 hours. This gives them time to adhere, and we flip the device over a couple times so that they seed evenly across the structure that we create. We then start perfusion at a desired shear stress. We let that run for 34 hours in order for the endothelium to form and react to that shear stress. And then we can inflame them using tissue necrosis factor alpha, histamine, or in some cases we use extracellular vesicles released from the primary tumor that are thought to prime endothelium. We let this go for 12 hours during flow, and then we do some imaging and analyze what the results are. And here's an example of a permeability study looking at the white dashed lines indicate where the blood vessel is. And this is 10 kilodalton fluorescent dextran perfusing into the surrounding matrix, and 70 kilodalton dextran as well. And we can look at these intensity profiles to measure permeability values of these systems. So here's just a snapshot of what we call a basal non-inflamed blood vessel. And so you can see that it forms really nice cadherin junctions with the surrounding cells, these sort of linear junctions that you would expect in a healthy endothelium. And you can see also the F-actin forming the cortical rings and some connections in between. Now, if we expose this to TNF-alpha at 10 nanograms per mil, you can start to see that these adherens junctions, these cadherins junctions have released, and they're kind of focal now. So the cells have sort of retracted from each other a little bit. And that is also corresponds with an increase in actin stress fibers, showing that these cells are going more from an epithelial state into a more mesenchymal state, right? So something we would expect upon inflammation. If we measure the permeability values of these systems before and after, so here's the permeability for 70 kilodalton dextran and 10 kilodalton dextran in our non-inflamed condition. Here we're getting about 1.25 times 10 to the 6 centimeters per second for our value. In vivo measurements are around 2 times 10 to the negative 6, and similar devices are between 1 and 2. So we feel like we're doing a pretty good job at least recapitulating the permeability values. And if we look at the same vessels after exposure to tissue necrosis factor alpha or to histamine, we see extremely large increases in the permeability of 10 kilodalton dextran and some more modest increases in 70 kilodalton. But this is indicating to us that we are getting an inflammatory response and increased permeability. So now we're really interested in how does that influence the ability for circulating tumor cells to extravasate from these vessels. So here the endothelium is shown in red. We're using human umbilical vein endothelial cells in this case, and we're using a triple negative breast cancer cell line, the MDA-MB231. And so you can see we can flow in these cells, they can bind and adhere to the endothelium and begin to extravasate out of the endothelium into the surrounding tissue. And we can see that we do have a number of events that occur in this non-inflammation or basal condition. Now, conversely, if we switch to an inflammatory condition, we see much higher levels of both adhesion to the endothelium and extravasation beyond the endothelium into the surrounding tissue. So this is telling us, okay, the role of inflammation on the endothelium is facilitating the ability for these cells to extravasate and form new metastases. So just again, a comparison of the basal and the inflamed, and here's some 3D renderings of both of those. So the question would be, how is this actually happening? So one thing that we think is happening is that these cell adhesion molecules that are known to be upregulated in inflamed endothelial cells are likely allowing the circulating tumor cells to bind under these inflamed conditions and extravasate out. So we've identified 5 that we think are playing a role: E-selectin, VCAM1, T245, CD37, and HCAM. And I'll show you a little bit of data of us using antibodies against E-selectin to try to block these processes. So here you're showing the number of bound circulating tumor cells to the endothelium. This is under the basal condition and exposure to TNF-alpha. We see a significant increase in the binding. And when we treat the endothelium for 6 hours prior with either 2, 5, or 10 micrograms per mil of an E-selectin antibody, we see a modest dose response where we can bring the number of bound circulating tumor cells down to the basal levels, indicating that we're potentially finding one target that's playing a role here. And similarly, we can count the number of extravasated CTCs over time. Here's what we see in our basal conditions over a 20-hour period. We see a significant increase upon exposure to TNF-alpha during inflammation. And then if we treat this TNF-alpha with an antibody, we can bring it back down to a basal condition. So we're on the right track. We're testing other antibodies to see if we can actually block these interactions as a treatment. So what I'll do now is I'll move quickly on to our size limitation studies and how we're trying to approach those to understand vascular architecture and facilitating this extravasation process. So we can make very simple structures, sort of engineered structures, if you will, that taper down and allow us to trap these cells and get an idea of what pressures and diameters they can handle that they can't flow through. But that isn't what happens in our body. So if we look at our vasculature in vivo, it's a highly dense, highly organized, highly spatially organized system. So we really wanted to ask the question, can we start recapitulating some aspects of this using engineered techniques? So we've developed a new technique. I'll describe it really quickly using 2-photon imaging. So for those of you that do a lot of 3-dimensional imaging, 2-photon imaging is sort of analogous to confocal in some ways, meaning that if you excite this fluorophore here in green with a single photon here at 360 nanometers, you can see that you excite this entire focal plane. But if you use 2 photons at double the wavelength, 720 nanometers, then the probability of those 2 photons hitting the same volume is very low. So you get an extremely small excitation volume, which limits the amount of fluorescence that you get. So this is how you get high resolution with multi-photon imaging. So what we do is, instead of using that small spots for imaging, we use it for photodegradation of hydrogels. So the way this works is we spend a lot of time trying to understand the physics. 2 minutes left. Okay. Sorry, I'm running a little bit late here. There are a number of methods that allow you to photodegrade these structures, and we can degrade them from about 2 centimeters per second to about 90 centimeters per second, depending on the material that we use. And what is interesting here is that we can create structures. So this is a vascular-derived microfluidic system that we fabricated, and this is an in vivo image that we use as the template to actually fabricate this structure. So now we can start creating these biomimetic in vivo-like structures. We can characterize and show that they work well. And then I'll end with one other slide here. So we've been working with Sylvie Latour in France in order to create synthetic networks that mimic the architecture of neurovasculature. So they used a bunch of human 3D images to characterize the morphology, topology, and hemodynamics of human brain microvasculature. They use a Veroni diagram in order to create these structures. And then we can fill a desired hydrogel volume space with an algorithm they created for us that has a single inlet and a single outlet that has an architecture that begins to mimic the neurovascular architecture. And here you can see we fabricated one of these systems and are flowing things through. So with that, I'll go ahead and end and thank my students who obviously did all this work, and thank you to Mary and Dave for giving me the opportunity to present.
Thanks, John. I think we have maybe 1 minute for questions. If anybody has a question for John.
I have a Hi, Jess Blubicki. I have a question about your neurovascular, modeling. Are you including any perivascular cells in these models, like pericytes or some of these novel perivascular populations that seem to be important for modulating things like blood flow and endothelial health?
Yeah, no, we have not done that yet. We've had many discussions with it. I saw some slides from Andy Shee's group in the previous presentation. We've worked with Andy quite a bit to think about including those. So we have not done it yet. Others have. So it is possible to do. We just haven't done it yet. We have included, I should say, we have included neurons or neural stem cells in the surrounding tissue. And we have created the endothelial structures out of BEN3, which are a mouse endothelial cell line, and also human-derived brain microvascular ECs from induced pluripotent stem cells in a collaboration with Kelvin Lee's group. So working more towards the brain side.
Okay, thanks, John. If you don't mind, stop sharing your screen. I think we will move on. Okay, it's my pleasure to introduce the next speaker, Dr. Chris Martens, who is also from the University of Delaware. He's from my home department, Department of Kinesiology and Applied Physiology. He is a project leader on our phase 2 COBRE as well, and he's going to talk to you about getting to the heart of Alzheimer's disease, cardiovascular risk, age-related memory impairment. Go ahead, Chris.
Got to unmute. All right. Thanks, Dave. I apologize if my voice sounds a little funny. I came down with a cold last night, but hopefully I'll get through this here. So I just want to start with an overview of Alzheimer's disease, talk about a little bit what it is and where progress or lack of progress has been in therapeutic development, and then segue into a discussion about how cardiovascular risk factors actually play a major role in the development and risk for Alzheimer's disease. I'll provide some cross-sectional evidence of this from larger epidemiological studies, as well as from our own lab in smaller studies, and then end with just a brief discussion about some current and future directions that we have planned in the lab to try to understand the mechanisms and hopefully lead towards some therapeutic options in the future. So Alzheimer's disease was first coined in the early 1900s, and as Dr. Nelson said, it's characterized largely by the formation of amyloid-containing plaques and tau neurofibrillary tangles in the brain, as well as severe shrinkage of the cerebral cortex in an area of the brain that we're interested in called the hippocampus, which is really important for the encoding and recalling of new memories. These pathological changes happen much earlier in life than the presentation of cognitive symptoms. So even in your 30s and 40s, you may start to develop some of these plaques and tangles that ultimately, in some people, progress on to a period called mild cognitive impairment, which then can eventually progress into more severe dementia that results in loss of functional independence, and in end stages may require 24-hour attention. Much of the pharmaceutical development for Alzheimer's disease has been focused on the clearance of amyloid plaques in the brain. And the fact of the matter here is that since 2002, almost 99% of all drugs in this area that have been tested have failed in clinical trials. And to date, we only have a handful of FDA-approved drugs for treating or preventing Alzheimer's disease, the majority of which do a moderately good job of addressing the cognitive symptoms without really doing anything to stop or reverse the progression of the disease. You may be aware of one recent drug that made headlines, aducanumab, which was approved for the prevention of Alzheimer's disease by the FDA this year, but it's a very controversial approval. It didn't meet all of the normal requirements for approval by the FDA for efficacy. And in fact, the FDA appointed panel that reviewed the clinical trials actually did not recommend approving the drug. So this leaves us maybe with more questions than answers, particularly for physicians and patients and caregivers asking, what next? What can we actually do to stop this disease? So there's a clear need for more novel therapies to treat or prevent Alzheimer's disease. Fortunately, Congress and the NIH have recognized this, and since 2015 have allocated about $3.5 billion towards Alzheimer's related research. and have a national goal of stopping the disease by 2025. So this was about the time that I became interested in Alzheimer's disease as I was transitioning from a postdoc into an independent faculty position. And my background is in cardiovascular physiology. And so naturally, I became interested in whether there's a cardiovascular role for Alzheimer's disease. And interestingly enough, if you look at the underlying risk factors for Alzheimer's disease, they mirror in many ways the risk factors for cardiovascular diseases. So advancing age, of course, is at the top of the list, but things like hypertension, diabetes, stroke, dyslipidemia, and vascular dysfunction are all present in individuals with Alzheimer's disease and appear to play a role. So this has caused us and others to ask questions of is Alzheimer's just another form of cardiovascular disease that affects the brain before it gets to the heart? So there's some larger epidemiological studies that support this idea, showing that the emergence of vascular risk factors, particularly when they occur during midlife rather than in later life, are predictive of future Alzheimer's disease risk, as well as the accumulation of amyloid plaques in the brain. And so, as Dr. Nelson mentioned, some of these vascular impairments tend to be one of the earliest changes that predict future Alzheimer's risk. And likewise, there's been several attempts in larger scale clinical trials to target vascular risk factors for the improvement of cognitive function or the prevention of dementia or mild cognitive impairment. And I'll just point out two studies here. The first one is a Finnish study called the FINGER trial. This was a 2-year intervention in which participants were randomized to either a control group or an intervention that was a multi-domain intervention, combining healthy diet with exercise, cognitive training, and monitoring of vascular risk factors. And the intervention group is shown here in the red line, and you can see that compared to the blue line, the control group, over the 2-year period, the intervention group had a greater increase in cognitive scores. Down below is an offshoot of a cardiovascular trial called the SPRINT trial, which was originally designed to test the efficacy of intensive blood pressure lowering therapy versus standard of care blood pressure therapy for preventing cardiovascular disease. But they created an offshoot trial called the SPRINT Mind study, in which they were also interested in determining whether intensive blood pressure lowering could also reduce risk of dementia or mild cognitive impairment. The graph on the right here shows the intensive treatment group over the 7.5-year follow-up period in yellow versus the standard of care treatment in blue. And these errors overlap here at the end, so it wasn't quite statistically significant, but it appears that there's a trend, at least for intensive blood pressure lowering, for delaying or reducing incidence of dementia over the follow-up period. And dementia was the primary outcome of this study, but when they did a subsequent analysis and looked at the incidence of mild cognitive impairment, the blood pressure lowering intensive treatment group did have a lower incidence of mild cognitive impairment, suggesting maybe that earlier intervention is more effective than delaying dementia. We should be going after people with more mild cognitive impairment. So my laboratory at the University of Delaware is interested in understanding the mechanisms by which cardiovascular disease risk factors may mediate this link between advancing age and cognitive impairment, in hopes of using that information to eventually develop interventions that can prevent or reverse cognitive aging. And one of these risk factors that we're particularly interested in is stiffening of the large elastic arteries. So the elastic arteries are the aorta and the carotid arteries, and they're elastic in nature, meaning that when the heart expands or contracts and ejects blood, these elastic arteries expand and recoil to help buffer that large pressure that's leaving the heart and deliver a more or less continuous flow to downstream organs and tissues, such as the brain. With advancing age, these elastic arteries stiffen, they lose their elasticity, and subsequently, when the heart contracts, the loss of this elasticity results in the delivery of more pulsatile flow to downstream organs and tissues, which we believe may have some cause some damage to the sensitive microvasculature in those tissues. We can measure the stiffness of the elastic arteries in humans using a technique called aortic pulse wave velocity. The way this works is we place a small pressure probe on the carotid artery and one on the femoral artery. And by simultaneously measuring a pressure waveform from each of these sites, and if we calculate the distance between the two recording sites and the time delay between these pulse waves, we can calculate the velocity of a pressure wave as it travels down the aorta. And a faster pulse wave velocity is indicative of a stiffer aorta. So these are data from our lab, but they represent studies that have also been published elsewhere in the literature, demonstrating a clear negative association between aortic pulse wave velocity and cognitive function. Here we have pulse wave velocity on the x-axis and delayed recall memory on the y-axis. And this is one of the domains of cognitive function that is most severely impaired in individuals with Alzheimer's disease. And so this is why we've become interested particularly in this domain of cognitive function. And you can see that those with higher pulse wave velocity have the lowest delayed recall memory. And so now we're interested in understanding what these potential mechanisms are, why elevated pulse wave velocity may contribute to delayed impaired memory performance. And so one of our working hypotheses, as I'll unveil over the next few slides, is that the increased pulsatile blood flow that is induced by the stiffening of the elastic arteries may be contributing to a loss of brain tissue integrity. So the way we measure the integrity of brain tissue in humans is through a technique called magnetic resonance elastography, or MRE. This is a non-invasive method that captures the mechanical integrity of a tissue, in this case, the brain. And we do this in collaboration with Curtis Johnson, an assistant professor in biomedical engineering at UD, who's an expert in this technique. The way it works is we place a subject inside of an MRI scanner, and we put a small pillow under their head that's connected to a pneumatic driver. And that pillow can then oscillate at a known frequency and introduce shear waves into the brain image in the X, Y, and Z direction. And then using an inversion algorithm, we can take those shear wave fields and extract from them information about the viscoelastic properties of the brain, including its stiffness and elasticity. And if we also capture a reference structural image, we can overlay these elastography maps over the structural image to get at the stiffness and elasticity of specific regions of the brain, such as the hippocampus. So when we first started going down this road, we were interested in the direct relation between stiffening of the elastic arteries and brain integrity with age. And I mentioned earlier that the elastic arteries become stiffer as we get older, and that's pictured in the graph on the left here, showing a very tight positive association between age on the x-axis and aortic pulse wave velocity on the y-axis. And in contrast, our brain tends to get softer as we get older. So again, age on the x-axis and the stiffness of the entire brain on the y-axis. And so our first question was whether the stiffening of the elastic arteries mediates this softening of the brain with advancing age. The problem is that both of these variables are tightly associated with age. And so to weed out the direct effects correcting for age, we ran a mediation analysis. And we were surprised a little bit to find that there was no mediation path between age and declining brain stiffness through increases in pulse wave velocity. So that got us thinking that if stiffness of the aorta per se is not related to brain integrity, perhaps the pulsatile blood flow that's induced by having a stiff aorta is the real culprit here. So we can measure the pulsatility of blood flow within the brain using another technique called transcranial Doppler ultrasound, or TCD. This creates a nice blood flow velocity waveform pictured in the box on the right, from which we can capture a systolic blood flow velocity, a diastolic blood flow velocity, and a mean velocity for each cardiac cycle. And using these three variables, we can calculate what's called the pulsatility index, which is simply the pulse velocity amplitude divided by mean velocity. So here are some data showing a negative association between pulsatility index in the middle cerebral artery and the stiffness of the hippocampus, and these have been corrected for age. And so independent of how old you are, individuals with higher pulsatile blood flow velocity in the brain tend to have a softer hippocampus. Now, I said just a second ago that pulsatility index is calculated as this pulse amplitude divided by mean blood flow velocity. And so when we break these data apart into their component parts, we were surprised to see no association with pulse amplitude in hippocampal stiffness, but a positive association between basal middle cerebral artery velocity and hippocampal stiffness, suggesting that those with low basal blood flow to the brain have a softer hippocampus and a greater overall pulsatility index. So a PhD student in my lab, Faria Sinjana, published a paper last year looking at factors, other cardiometabolic factors that may mediate this decline in brain tissue integrity with age. And one factor that she found was that elevated triglycerides in the blood were negatively associated with the viscoelastic mechanical properties of the hippocampus. Pictured here, you can see that individuals with elevated blood triglycerides have lower elasticity within the hippocampus, and these are corrected for age again. And then on the right, just a representative image showing a person with low triglycerides compared with a person with high triglycerides. And the person with high triglycerides has a softer and less elastic hippocampus. She's also recently shown in some unpublished data that those with elevated triglycerides also have reduced reactivity of the middle cerebral artery to a vasodilatory challenge. So one of the techniques that we utilize is, again, using transcranial Doppler ultrasound. We have patients breathe from a face mask that contains or delivers room air and then air supplemented with a small amount of carbon dioxide to stimulate vasodilation within the cerebral blood vessels. And shown here, individuals with elevated triglycerides have diminished reactivity of the middle cerebral artery. And so we're now thinking that perhaps these other cardiometabolic risk factors like elevated blood lipids may contribute to cerebrovascular impairment and play a role in this increase in cerebral pulsatility in the brain, leading to cognitive impairment. So where we're focused now is understanding how triglycerides become elevated in the blood in the first place in order to get at what we might be able to do to resolve this. One of the ways that triglycerides are produced endogenously is from fructose, which is abundant in foods containing a lot of added sugar. So in the liver, when we ingest fructose, it's converted to acetyl-CoA and then into triglycerides, which are transported in the blood through very low density lipoprotein particles. And when we took a look at dietary records from individuals who have come through studies in our labs, those who consume greater than 10% of their daily energy intake from added sugars, which is the current recommended cutoff for added sugar intake, these individuals tend to have higher blood triglycerides and large VLDL particles in their blood. So in closing, my last slide here is just our current working model and where we're going from here. We believe that individuals consuming high amounts of added sugar in their diet may have elevated blood triglycerides that contribute to vascular impairment and loss of integrity of the hippocampus, and that this may be a mechanism contributing to loss of memory function with aging. And so we're happy to have been included in the phase 2 renewal of our Cobre Center for Cardiovascular Health. And our project will be a randomized crossover study in which we'll take midlife adults and place them on high and low added sugar diets and compare changes in arterial function in the brain as well as their hippocampal integrity. So with that, I'd like to thank the members of my lab who contributed to this work, as well as the IDEA-supported grants that we have and other grants in the lab. And I'd be happy to take any questions if there's time.
Thanks, Chris. We have a couple questions in the chat. So Denise Peters asks, have you looked at other brain regions of interest besides the hippocampus?
We haven't yet. We've been focused on the hippocampus. Some of the work that it goes into taking the viscoelasticity maps of the brain and then deciphering viscoelastic properties in specific areas of the brain is a little bit challenging. And so we have the framework set up right now for isolating the hippocampus, but we're interested in exploring out from the hippocampus into other areas that are affected early on in the progression of Alzheimer's disease. We just haven't gotten there yet.
Okay, one more quick question. Have you looked at whether blood-brain barrier permeability increases with pulsatility?
We haven't looked at it directly, but there is evidence from animal studies and also in vitro hydrogel type studies like John talked about, showing that as pulsatility goes up, the shear stress against the endothelium changes, and this has been directly linked with a loss of blood-brain barrier integrity. So it would make sense that more pulsatility would contribute to a breakdown of the blood-brain barrier.
Okay, thanks, Chris. I'm going to turn it back over to Mary.
This is great, thanks. So Chris, if you could unshare, great. So I'm really pleased to introduce Dr. Fabiola Munarin, and she comes to us from Brown University School of Engineering. It's great to see people coming from a variety of different types of colleges at their institution. She is a pilot project PI in the Cardiopulmonary Vascular Biology COBRA at the Ocean State Research Institute, affiliated with Brown University, and she's an assistant professor in engineering. So welcome, and look forward to your presentation.
Thank you. Thank you very much. All right. So thank you, Mary. It's a pleasure for me to be here today and share some of my work that I conducted at Brown University. And in particular, today, I will be talking about how we design biomaterials with immunomodulatory and angiogenic properties for treating ischemic injuries, including myocardial infarction. So cardiac repair after a myocardial infarction results from a finely orchestrated and complex series of events, which basically start with an acute inflammatory phase in which the cells of the immune system rapidly invade the MI to clear dead cells and extracellular matrix debris. And this phase is followed by a resolution and repair phase, which usually occurs between 4 and 14 days after the injury, in which there is a switch in the phenotype of these immune cells. Myofibroblast proliferation is observed, as well as new vascularization starts to occur. However, for large infarcts, cardiac remodeling is visible and it is manifested as a dilation of the ventricles, which ultimately results in chronic and ischemic heart failure. In this case, there is extensive tissue infiltration with cells of the immune system and a persistent state of chronic inflammation. So the objective of my research is to develop biomaterials for controlling the release of immunomodulatory and angiogenic cues to instruct the host immune system for promoting regeneration and repair in the cardiac tissues. The scheme that you're looking at here basically show what happens to the immune cell population and specifically to monocytes and macrophages during the reparative processes after an ischemic injury. Monocytes and macrophages are polarized from pro-inflammatory to pro-healing subsets, and then usually between the 4 and 14 time frame, they start producing some angiogenic factors which are initiating the regenerative process and the new vascularization process in the ischemic site. And this process is mediated by cytokines, including colony-stimulating factor 1, interleukin 4 and 13, and of course by other growth factors, which are basically promoting angiogenesis on endothelial cells. So the aim of this work is to try to deliver colony-stimulating factor 1 and other anti-inflammatory interleukins, as well as pleiotrophins as a potent pro-angiogenic factor to try to accelerate the reparative process. And of course, to deliver the cytokines, we want to use biomaterials for a localized and sustained delivery of these factors. We use alginate as a biomaterial of choice because this is widely available in nature, biocompatible. It has been extensively used for producing hydrogels for tissue engineering applications in different physical forms, including bulk hydrogels, microspheres, injectable gels, and it's FDA approved. However, to basically improve the retainment and the delivery of growth factors from these biomaterials, we want to introduce heparin moieties on alginate backbone with a chemical modification. So to mimic what happens in the natural extracellular matrix, where growth factors and heparin that contains heparin binding domains are bound to heparin moieties in the proteins of the extracellular matrix. And we can do that by EDC chemistry, where we are able to basically covalently bind heparin to the carboxylic groups of the alginate backbone. And we aim for a 10% activation of the carboxylic groups, as we still need to have some carboxylic groups available for alginate gelling. To confirm that the reaction occurs, we can use FTIR spectroscopy. And as you can see here from this enlarged portion of the spectra, we can see in the modified alginate the appearance of some peaks at 1200 and 900 centimeters -1, which are associated to the presence of heparin on the alginate backbone. So, as the first in vitro characterization that we wanted to perform, we wanted to see the release profiles of a model protein from these chemically modified alginate materials. And by mobilizing pleiotrophine into alginate gels and incubating the gel in an incubation solution, which is usually PBS at a physiological pH and temperature, we are able to measure the release kinetics of pleiotrophine from these gels. And we can see a pretty extensive release, which spans over usually 10 to 14 days, which is a very good release compared to the non-modified alginate biomaterials, which usually show a burst release in the range of 2 to 3 days. Going in vivo with this model of using a model protein, which is a FITC labeled BSA, though, we did observe a very different result. So using the same materials injected in vivo containing a FITC labeled BSA, we did see a burst release. So at 2 days, all of the BSA mobilized in the gel was completely released. And so this is why we had to re-optimize our gel with the addition of chitosan, which is another positively charged polymer, which was used in combination with the alginate to provide increased entanglement in the polymeric chain and polyelectrolyte complexes with alginates to better retain the proteins in the gel, and so to provide a more sustained release of the cytokine over time. The way we measure the cytokine is this in vivo assay is at explant, we are able to measure and detect and measure the BSA remaining into the hydrogels by fluorescent microscopy. So the next question that we want to answer is now, are these growth factors that are released from the alginate gels effective in polarizing the cells of the immune system? And so we took the extracts from these hydrogels loaded with different combinations of immunomodulatory cytokines, including colony-stimulating factor 1 and different types of anti-inflammatory interleukins. And we used these extracts to treat CD14 positive monocytes isolated from human blood, peripheral blood. And the images here on the right show that using colony-stimulating factor 1 in combination with different anti-inflammatory interleukins promoted polarization of these monocytes into macrophages. And further analysis with immunohistochemistry using CD163 and CD206 antibodies, which basically stained for the pro-healing macrophage subsets, allowed us to estimate the numbers of cells of monocytes that would be polarized into pro-healing phenotypes, and allowed us to show how using a colony-stimulating factor 1 in combination with a cocktail of anti-inflammatory cytokines would promote the polarization of macrophages from pro-inflammatory to pro-healing phenotypes. So next, to assess the potency of pleiotrophine as a promoter of angiogenesis in vivo, we tested the matrigel plaque formation assay, which basically consists in mixing pleiotrophine at different concentrations with matrigel, which is injected into the animal and explanted at different time points. We chose to use a very early time points here, 1 and 4 days, because we were expecting rapid angiogenesis in these hydrogels. And as you can see from in this image here, increasing concentrations of pleiotrophine resulted in an increased vascularization of the hydrogels, seen as a marked change in the color of these explants, which is related to the increased presence of hemoglobin into these hydrogels. We then decided to repeat this experiment using our hydrogels loaded with pleiotrophine instead of the matrigel matrix, and could basically show the same results. So using increasing doses of pleiotrophine in the hydrogels, we did see increased vascularization in the subcutaneous implants. And then performing immunohistochemistry in these hydrogels, what you see here, A and C are unloaded hydrogels, B and D are hydrogels loaded with pleiotrophine. We could definitely see an increase in the number of endothelial cells recruited into the hydrogels as expected, as well as an immune cell population recruited in the hydrogel that was partially composed of pro-inflammatory and partially composed of pro-healing phenotypes, which is what we would expect at 4 days in a normal granulation tissue following an ischemic injury. To further assess the ability of pleiotrophine to drive angiogenesis in a hypoxic environment, we continued with the characterization of these by materials with a matrigel tooth formation assay. This is a mid-throughput assay that we can perform in a 96-well format, and we use iPSCs-derived endothelial cells seated in each well over a layer of matrigel, and we can monitor how these endothelial cells are able to form networks over time in hypoxic conditions. And usually network formation peaks for these cells at 8 hours. After that, there is sort of a pruning of vessels, which is due to the fact that we're not using any support cells or any growth factors to support the formation of these networks. However, it's possible to see that at 8 hours, increased network formation is visible with increasing concentrations of pleiotrophine up to 500 nanograms per ml. And so by quantifying the area covered by vessels, the total length of the vessels, number of branch points, and also their diameter, we are able to show clearly a dose dependence for pleiotrophine, especially at 24 and 48 hours. So the cells that received higher concentrations of pleiotrophine in the range 200 and 500 nanograms per ml, which are the darker blue bars here, showed statistically a statistical difference compared to the test medium, to the cells treated with test medium, which is the regular endothelial cells medium stripped from VEGF and BFGF, the angiogenic factors, and showed comparable vessel formation to the cells that were treated with the complete endothelial cells medium. So we did have very promising results here using pleiotrophine as a factor for inducing angiogenesis in our samples. We do believe that now immobilizing those factors into the biomaterials and so tightly controlling the release of pleiotrophine in vivo would also promote angiogenesis in a more effective way. I'm going to show you now, just to conclude, a couple of in vivo models that we are using to simulate ischemic wound healing. The first model is an ischemic skin flap model that we use as a predictive model for ischemia. We do create ischemic wounds in the back of rats, and we do create a skin flap to insert a silicone sheet between the skin and the underneath muscle, so that these wounds cannot be revascularized. And so the process of wound healing recapitulates what happens in a chronic wound healing with minimal vascularization of the wounds, and so delayed repair of the wounds. And we can implant our biomaterials here containing the immunomodulatory cytokines and monitor wound healing by basically measuring the diameter of the closing wounds over time. As you can appreciate from this graph, when we use our biomaterials loaded with cytokines, we do have and we do see an accelerated healing of these ischemic wounds compared to the wounds that were treated with the unloaded biomaterials or the ischemic wounds that did not receive any implant. And of course, wounds that are performed as a control in a non-ischemic environment usually heal faster, and usually at 14 days, these wounds are already completely healed. So because we did see this accelerated trend of repairs in this in vivo model of ischemic skin wound, then we wanted to test these biomaterials also on the heart with an injectable alginate biomaterial formulation. We did perform myocardial infarction by ischemia reperfusion, followed by injection of the alginate materials containing the immunomodulatory cues. And we monitor heart function by echocardiography up to 15 days, showing an improvement in cardiac function in the loaded hydrogels compared to the group of animals that received only a control saline injection. And this was also associated with a reduction in the number of the pro-inflammatory macrophage subsets that were detected in the infarct area and stained with CD80. But this was not associated to an increase in the number of pro-healing macrophages subsets. This is because probably the MI is a very complex chronic wound and like we will probably need to re-optimize this system to also push this transition of macrophages from pro-healing to from pro-inflammatory to pro-healing phenotypes. So to conclude, we have demonstrated that a localized release of colony-stimulating factor 1, interleukin-4, and pleiotrophine released from alginate biomaterials can improve immune cell polarization towards reparative phenotypes and angiogenesis. heart function experiments that we first conducted on a model of myocardial infarction showed improved function at 15 days. With these, when this biomaterial system was injected. And we could also observe changes in the immune cell population in the infarct environment with a reduction, visible as a reduction of the inflammatory phenotypes in MI. And our future work will be focus on trying to understand how to better leverage those immune cells to also improve a polarization of these macrophages into pro-healing phenotypes. So with that, I would like to acknowledge my group, the Coulomb Lab, collaborators, mentors. Thank you all for your attention and for inviting me here today. And I'll be happy to take any questions that you have.
So if you can unshare your screen, please. We have
Sure.
time for maybe one question. So if someone would like to raise a question, Dr. Plavicki has her hand up.
Hi, great talk. I was curious about what your thoughts were for promoting that pro-resolution macrophage population, if you had any strategies in mind on how to recruit more of those, or to, I know at some cases at wound sites, you can have metabolic reprogramming towards a pro-resolution phenotype. So I'm just curious what you're thinking in that realm.
Yes, so that's a great question. The strategy that we were envisioning was to investigate, to work basically on growth factors and how growth factors can be secreted by these macrophages that are present in the infarct during the first phases of repair. And during also the acute inflammation phase. So as I was showing you before, we showed that using a cocktail of factors dramatically improve the number of macrophages that are polarized from the pro-inflammatory to the pro-healing subsets. For these in vivo study that I showed here, we only used colony-stimulating factor 1 and interleukin-4 because this was the most simple system that showed in vitro some difference in polarization. But we also show in vitro that using the cocktail of multiple interleukins, anti-inflammatory interleukins, could improve these even more. So the next step of this project is short-term, would basically to test these cocktails of cytokines to see if what we do see in vitro can be recapitulated in vivo. We wanted to go first with a very simple system to reduce the number of variables for our in vivo study, but probably we will need to use the full cocktails that we have assessed in vitro as well. So this would be the first strategy.
I'm sorry, we're gonna have to move on, sorry. We're getting a little behind. So,
right.
So thank you so much. I'm gonna turn this back over to Dr. Edwards.
Thank you very
Thank
much.
you.
Thank you.
It's my pleasure to introduce Dr. Jessica Plavicki. She comes from the Warren Alpert Medical School of Brown University, also a member of the Rhode Island Cardiopulmonary Vascular Biology Cobra at Ocean State Research Institute, Providence VA Medical Center. And she's going to talk to us about using the zebrafish model to understand brain and heart health. Go ahead and take it away.
All right, let me share my screen here. Okay. All right. Thanks so much for this opportunity to talk about work that's happening in my lab that has been supported in part through the Cardiopulmonary Vascular Biology Cobra at Brown University. So I'm going to start by telling you a little bit about why I think the zebrafish model is an excellent model for studying the interaction between brain and heart health. And then I'll tell you a little bit about some of the research questions that we're addressing in my lab, and in particular focus on our studies manipulating the aryl hydrocarbon receptor and how that has implications for both brain and heart health. Zebrafish are a wonderful model that have been heavily used in developmental genetics, in part because they are initially transparent and they develop rapidly. So you can see here, at 10 minutes post-fertilization, a one cell staged embryo, and 24 hours later, we have discernible organ features, a pumping heart. And then by day 5, we have all of our organ systems online. And of course, they undergo growth and maturation as the fish grows, but this is really rapid development. And in addition, because these embryos are developing in an aqueous environment, they can rely on passive oxygen diffusion. And so that means that we can use both forward genetics and reverse genetics to look at cardiovascular malformations or mutations in genes that produce severe cardiovascular malformations, which might otherwise be lethal in a mammalian model. Importantly, while we don't look like fish, we share the same physiological systems as fish, and the fish model is used to study CNS development, cardiovascular development, as well as development of all major organ systems. And importantly, we have a high degree of conservation between humans and fish. So about 70% of human genes have an obvious zebrafish ortholog. There are also important differences between the fish and human models. So fish are highly regenerative, and people want to understand how to capture this regenerative capacity to treat human disease. Here you can see in this first panel, a tail fin in an adult zebrafish. It's amputated, and then 30 days later, you can see significant regrowth of all of the features of the normal tail. While you may not have tails that you need to regrow, we do have hearts that we need to repair, as well as spinal cords. So this regenerative capacity extends into these other major organ systems. So there are a number of different ways to introduce heart injuries into a fish. You can have a resection of the ventricle itself or introduce a cryo injury. But what happens is you normally have this formation of a fibrotic scar, but then that scar resolves, and then you have that tissue replaced with functional myocardium, as well as integration with the coronary vasculature and epicardium. And importantly, this extends to the nervous system, where we can see in a spinal cord resection model that the formation of a glial bridge facilitates the functional connectivity of these two separate halves of the spinal cord. So while the fish model has been used heavily during early embryonic development, there's an increased interest in expanding the fish model to understand human disease and to model different types of human disease. In addition to sort of the shared physiology and genomic considerations, we also have a suite of transgenic tools that are readily shared within the community. Due to the really small size of the embryos, and just to give you some sort of perspective in case you haven't seen a zebrafish embryo, these are about the size of Lincoln's nose on a penny. So they're initially very tiny, and then they grow to about 2 inches in length. And so we have transgenic markers for most cell types, and here we have an image of a dorsal view of a zebrafish brain, in which the brain is marked in green, or at least the neurons are, and then blood is in red. So we can look at blood flow completely within an intact developing embryo. We can look at a number of important and interesting cellular interactions. For instance, here we have macrophage in magenta, and we have vessels in green. And again, this is in vivo imaging. We can also do time lapse, which I'll show you an example of in the next slide. And we can look at interesting perivascular cell types such as pericytes, as well as subsets of neurons like radial glia. And then importantly, we can also have, we use genetically encoded calcium indicators to look at brain function in the context of different genetic manipulations. Finally, because they're so small, we can also do standard histology techniques like fluorescent immunohistochemistry, but we don't need to section, at least in the embryos and larvae. So we can, for a couple of weeks, have fully intact structures, which allows us to look at connectivity in great detail. So in this image here, I'm showing you a zebrafish larvae that's been stained for acetylated alpha tubulin. And it's just been color coded for depth, so we can really see where our different neuronal tracts are relative to one another. In addition, because of the small size, we can see the entirety of the cerebral vasculature in an intact embryo. And this is just an example of a 3D reconstruction of the cerebral vasculature in the zebrafish, and I've just rotated so we can really see all the different features, connectivity, we can assess lumen formation, we can assess things like angiogenic sprouts, etc., and perfusion. So there are a number of different research questions that are being addressed in my lab. I'm going to highlight 3 that I think are relevant to today's theme. One is, how does environmental exposures to contamination impact brain and heart health? And I'll focus on that topic in particular. We're also interested in understanding these non-canonical functions for macrophage during development, and we have some really exciting data indicating that we need macrophage to electrically couple with cardiomyocytes during development to form the cardiac conduction system. And we're also interested in other sort of physiological interactions, such as how premature follicular loss may impact cardiovascular health and then subsequent brain health. I'm going to focus on this issue of environmental contamination today because I think that as we wrestle with these issues of climate change, superstorms, and toxicant mobilization, as well as issues such as increases in forest fires, we're going to be focused more on how our environments are directly impacting human health. And I think that while this has been a topic of research for a long period of time, people who study human health often aren't thinking about how environmental exposures modulate human health to the same degree. There really seems to be a siloing of disciplines. But as we move forward, at least within our medical school, we see that there's an interest, a growing interest in this topic. And there's been the formation of a new track called planetary health to grapple with some of these topics. Okay, so today I'm going to tell you about some work that's related to the aryl hydrocarbon receptor. So we're particularly interested in different types of contaminants that can interact with this ligand-activated transcription factor. So AHR is found in the cytosol of mammalian cells and all vertebrate cells. It's normally found in this complex with some heat shock proteins and a chaperone protein called ZAP2. There are endogenous ligands for AHR, which were really just identified relatively recently compared to what we've known about the exogenous ligands for AHR. And most of those endogenous ligands are tryptophan metabolites. The exogenous ligands that have been identified come from both natural and anthropomorphic sources. So we have volcanic eruptions and forest fires that produce AHR agonists. I will also mention one of the complexities with forest fires is that we're not just burning organic material here, we're burning lots of different things that were never intended to be burned. So we have these really complex mixtures of chemicals that are being released into the environment and also interacting with existing air pollution issues such as ozone. There are a variety of different processes that produce AHR agonists that humans engage in, like pesticide and herbicide production, as well as different commercial products too. So PCBs, many of which have been banned, were used for various degreasing and caulking agents. However, they're highly persistent and not easily degraded in the environment, so they stick around for decades upon decades. Polycyclic aromatic hydrocarbons are found in a number of different combustion products, including the burning of medical waste and forest fires and cigarette smoke. And then TCD, which is a really potent AHR agonist we use as our sort of pharmacological manipulation to induce AHR activation. All of these exogenous ligands can enter into the cell because they're lipophilic to some degree. They cause AHR. They bind AHR, which causes this ZAP2 chaperone protein to release, which reveals a nuclear localization signal. AHR enters into the nucleus where it then sheds its heat shock proteins, interacts with dimerization partners such as ART, which is also HIF1 beta. And together AHR and ART bind these XREs, which are consensus sequences in the DNA, and then modify gene transcription. And this exogenous AHR activation produces these different profiles of altered gene expression, which then can disrupt development and contribute to disease progression. And work from our lab and from Robin Tangwade's lab at OSU have identified a key molecular mediator of these developmental disruptions, a gene called SOX9B, which is a high mobility group transcription factor that has diverse functions in organogenesis. So what we know about AHR is that if we use TCD to probe how AHR activation globally changes health and physiology, we see that exposure to TCD during early stages of development produces a number of different cardiovascular endpoints, including hemorrhaging. Here we have examples of a larval zebrafish with, again, the brain in green and the blood in red. These are live images. You can see the vessels perfusing the brain here. And then following exposure to a 1 part per billion dose of TCD, we see hemorrhaging and blood filling the ventricles, as well as hemorrhages in the brain parenchyma. For the sake of time, I won't tell you about all the endpoints that we've characterized, but we have found a reduction in angiogenic sprouts in different brain regions. We've seen a loss of pericytes, reduction in GLUT1 expression in brain endothelial cells, as well as changes in different efflux transporters. So we know that the vasculature is a target of AHR-induced toxicity. And we also know that the heart is a target of AHR-induced toxicity. And so early embryonic exposures produce a variety of heart malformations. And one of the critical factors that happens is that you have a loss of the proepicardial progenitor cells that give rise to the epicardium. And this is a lethal phenotype. So if you have an exposure that happens post proepicardial cell development, you still have an impact on the epicardium, but the phenotypes are not lethal. These later exposures also produce dysfunction in the myocardium, a change in calcium handling. And we wanted to sort of understand, given the fact that AHR is expressed in all of these different cells throughout the body, what cell types are really the targets of toxicity. So to address this question, we developed a plasmid with Dr. Kevin Lemnum from the University of Wisconsin-Madison, in which we took a myocardial specific driver to activate AHR in a constitutive fashion so that it was did not rely on ligand binding. So this allowed us to activate AHR in specific cell types. And in this case, we found we were able to recapitulate many of the cardiac phenotypes by just driving expression in the myocardium. However, we did not see a loss of these proepicardial progenitor cells, suggesting that both cardiomyocytes and proepicardial progenitor cells are targets of AHR-induced toxicity. So to extend on this idea, as well as to work towards the goal of having both spatial and temporal resolution, we decided to generate a number of transgenic lines that relied on the use of the GAL4 UAS system. So in this case, we have different cell type specific promoters that are fused to a transcriptional activator GAL4. And then in a separate line, we have a upstream activating sequence that is fused to a constitutively active AHR that also has a fluorescent reporter. And then we can cross these fish, and everywhere we have the UAS, everywhere the GAL4 is produced in the cell type, it will bind the UAS and then drive expression of AHR in a ligand-independent fashion. So we are now in the process of developing inducible versions of these so we can activate AHR in the myocardium and other critical cell types in the heart at different times in development, and separate that out from what we are seeing in other parts of the body. In addition, because we know that SOX9B is a critical modulator of AHR-induced toxicity, we wanted to understand or better understand the functions for SOX9B in cardiovascular development and in brain development. And so we know that SOX9B is expressed in the developing heart, in the myocardium, epicardium, and in the outflow tract. And in the brain is expressed in progenitor cells as well as neurons. And we are in a subset of glial cells. We're still characterizing some of the later expression patterns. But in both the heart and the brain, the expression is maintained, suggesting that AHR activation may impair SOX9B function across the lifespan. So to manipulate SOX9B, we decided to develop a dominant negative construct. And what this is that we have our normal SOX9B here, which has a high mobility group domain, which interacts with DNA, and it has a number of transactivation domains. And this C-terminal transactivation domain is really the one that allows it to interact with the transcriptional machinery that allows it to do its functions as a transcription factor. So when we created a truncated version of this, we removed this C-terminal transactivation domain, and then we're able to still have the construct bind DNA, but it couldn't interact with transcriptional machinery. Therefore, it couldn't induce transcriptional changes. We validated this in vitro, and then in vivo, we've been using this again with the Gal4 UAS system to manipulate SOX9B in a cell type specific manner. And we found that many of the adverse endpoints that we found following AHR agonist exposure could be recapitulated by activation of SOX9B in cardiomyocytes themselves. And we're really interested in understanding is, because of the expression pattern being maintained, what happens when we have activation or expression of the dominant negative at later time points in development and in the mature heart. So this is sort of getting at some of those questions. You know, some of the things that we're currently addressing is, how does juvenile and adult exposure to AHR agonists affect heart health and brain health? How does myocardial, vascular, and epicardial specific activation of AHR affect adult heart health, and how do these changes in the heart then impact the brain? So we want to separate the impact on the brain and the heart separately, and then examine the interaction. And then we really want to explore some more of these novel functions for SOX9B in development and in organ homeostasis. And I just want to sort of come back again to the model. So in order to do this, we are not only generating these inducible transgenic constructs, we also have up and running a number of different approaches that have not really been used much in zebrafish to understand heart health better. One of this is to do EKGs in zebrafish, and as you can see, the human trace and the zebrafish trace look very similar, and so we have this is an example of a recording from our lab. So we have this working in juveniles and adults, and we're trying to get this in embryos. But we're in the process of then figuring out the analysis pipelines to really understand. We're starting to see things like arrhythmias, which is very exciting. And then in addition, and this has been supported through our cardiopulmonary vascular biology COBRI, was the purchase of a transducer that is allowing us to do echocardiograms in zebrafish. And here you can see a zebrafish that is anesthetized, and then we can do all the same sort of measurements that you would do in a mammalian model, which is really exciting. And we're starting to see some really exciting results in that realm as well. And finally, we are building swim tunnels so that we can have a physiological stressor to then ask, how do our cell type specific manipulations in the heart translate into functional changes in behavior? So in conclusion, I just want to, I hope I've convinced you that zebrafish are a great model for studying brain and cardiac development, as well as the interaction between brain and heart health. I hope that you are thinking about how our environments may be impacting our cardiovascular health, in addition to nutritional and activity considerations. And I hope that you're thinking maybe SOX9B might be a critical mediator of some of these developmental processes, as well as these adverse endpoints. And finally, we've developed a suite of transgenic tools that are just starting to realize their capacity for understanding the impact of both of these genes in heart health and brain health. And I will end by thanking the people who have been involved in this. Shannon Martin, who has been involved in both the SOX9B work and the macrophage function in cardiac development work, as well as Lyra Citron-Rivera, who's been leading the SOX9B project as well, and Michelle Kozak, who is doing the work with AHR, as well as the follicular degeneration in heart health. And I'd like to thank, obviously, the COBRI for financial support, as well as our NIH funding. And I think that is it. I'm happy to take any questions. Now I'll leave you with this Onion article headline that made you feel very seen.
Thank you very much. That was great. I think we've got time for one question if anybody has one. Maybe in the meantime, if you could stop sharing your screen.
Oh, yeah.
That'd be great. I've got just one quick question. So I think this is a really important topic going forward, these environmental factors. So given that, forest fires have been happening on the western part of the country for a number of years, right, intensifying. Is there evidence of, increased cardiovascular and brain issues that we know of?
I don't know that people have linked it directly. There's been a lot of focus on pulmonary health. So people looking at the interaction of different compositions of air pollution. A lot of times people think of, I'm not an air pollution person, but a lot of times people think of air pollution being all the same, but it's really complex and it changes, and it can change regionally and daily and all of that. And so people are starting to look at air pollution and its relation to neurodegeneration. And so I think that a natural extension to that will be, that's been mostly traffic related air pollution. So I think people will be extending that to look at air quality issues that include things like forest fires, in addition to, pollution that's generated through traffic, et cetera. So I think that's very much on the horizon. There's some nice work at UC Davis focused in that area.
Great. All right, thanks very much.
Question?
Yep, go ahead, Mark.
Enjoyed your talk, Jessica. Yeah.
Yeah.
I was wondering about the blood-brain barrier in the zebrafish. Is that similar to humans or mammals?
Yes, it is. So I would say the only significant difference is that it really seems that radioglia are more of the sort of astrocyte role, but you have everything else, basement membrane, pericytes, similar molecular markers, similar signaling transduction that introduces, barrierogenesis and things like that. So there's a really good degree of conservation, and it's just beginning to emerge as another model. And it's sort of like its own little microfluidics device.
So, and one quick question, what's the heart rate of a zebrafish?
It's around 110 in an adult.
Oh, okay, I thought it was higher. Okay. Nice prep.
Okay, thanks.
All right, thanks again. Appreciate it. I'm going to turn it back over to Mary to introduce our final speaker.
Great, thanks so much. That was a great talk. Thanks, Jessica. So I want to move on to our final presenter, and this is Dr. Denise Peters from the University of Vermont College of Nursing and Health Sciences. She is a physical therapist by trade and an assistant professor in the Department of Rehabilitation and Movement Science. And she's a project director on our Vermont Center for Cardiovascular and Brain Health, COBRA. The title of her talk is Predicting Recovery Potential After Stroke. So Dr. Peters, if you can unmute yourself and get started.
All right.
That would be great.
Okay.
Thank you.
Thanks, Mary. All right, thank you. Again, the title of my talk today is on predicting recovery potential after stroke. And some brief background before I kind of get into some my data. Motor impairment and recovery after stroke is associated with many variables. It's been associated with lesion size and location, adaptive processes in the ipsilesional and contralesional hemisphere, such as reorganization of perilesional brain areas, secondary motor area contributions, etc. And recent studies using diffusion tensor imaging techniques have shown that structural brain integrity and connectivity also play an important role in the degree of motor impairment and recovery after stroke. All of that said, however, recovery of motor function can vary considerably from patient to patient, even those that have similar structural MRI scans. So what's needed is an increased understanding of clinical predictors and biomarkers associated with motor recovery and response to therapy after stroke. Such insight can help improve accuracy of motor recovery prognosis, can help with targeting therapeutic interventions, so really leading to more personalized medicine, and can help optimize patient resources and inform our discharge planning. So now I'm going to talk about neural and physiological mechanisms shown to be associated with different stroke outcomes, specifically independence and disability, upper extremity recovery and walking recovery, and prediction tools that have been developed for these outcomes. But first, there are some key features that need to be considered in order for prediction tools to be clinically useful. One, they're needed at the beginning of recovery after stroke. Two, they need to make a prediction for a specific time point, such as 3 months or 6 months after stroke, rather than outcome at hospital discharge. 3, they should be meaningful to the patients, like being able to predict the likelihood of achieving a certain level of function instead of some obscure score on some measure that means nothing to them. And 4, they should just combine a small number of variables in an easy way so clinicians will actually use the tools. So here are 3 independence and disability prediction models on this slide. And in general, independence and disability after stroke has been shown to be related to several factors such as patient age, sex, comorbidities, etc. And these 3 studies have combined these factors into prediction tools. However, independence and disability is a really global metric. And for many patients, what's more meaningful is, again, prediction of, they want to know, am I going to be able to use my hand again? Am I going to be able to walk again? So while these prediction models have been useful, other prediction models might actually be more informative, especially to the patients. So now I'm going to talk about upper extremity impairment and recovery after stroke. And the cortical spinal tract has been the main focus of research here, as it's the main motor pathway for distal motor control. And research has shown that degree of lesion cortical spinal tract overlap, not just lesion size alone, is a major predictor of residual upper extremity motor function. Additional research has shown that microstructural integrity, as commonly assessed by measures of fractional anisotropy, has shown that greater CST-FA asymmetry and or reduced IPS lesional CST-FA correlates with poorer arm and hand function. Additionally, microstructural changes in other tracts, such as transcolossal fibers and other brain regions, such as the red nucleus, have also been associated with upper extremity impairment and recovery, such that higher FA values have been associated with better motor outcome. And you can see some research from our lab in the bottom right-hand corner here that again showed that when looking at a measure of white matter integrity in the cortical spinal tract and the red nucleus, FA in both of these regions correlated with 3 different measures of upper extremity motor performance. So again, this kind of leads us to talking about there are broader changes that happen in our sensory motor network after stroke. And this is a good segue for me to talk about structural connectivity between brain regions and residual motor function. So altered structural integrity of white matter occurs not only in the lesioned area, but also in brain regions and motor tracts beyond the infarction site. And this is commonly referred to as diaschisis. And this is where you have your lesion. And previously all these white matter tracts would course through this area to reach other brain regions. Well, now this information can't course through the dead tissue. And so these other brain regions are not being optimally stimulated, and thus they undergo neuroplastic changes, which can also contribute to behavioral deficits. And we've shown in our lab that when looking at structural connectivity between a kind of a predefined sensory motor network, which you see over here on the right, connectivity between cortical subcortical regions, as well as interhemispheric connectivity between the primary motor cortices has been associated with upper extremity motor performance in chronic stroke. More specifically, when we looked at all of the white matter fibers going into the IPS lesional primary motor cortex, we found that primary motor cortex disconnection explained a significant amount of variance and was an independent predictor of upper extremity motor performance, again in chronic stroke. So here are some current upper extremity prediction models in the literature, and these are 2 of the more common ones, the PREP1 algorithm and the PREP2 algorithm. Kathy Stenier and her colleagues down in New Zealand are the researchers who have developed these models. And both of these models begin with a very simple clinical bedside test. So here they call it the SAFE score, which is really just a measure of shoulder abduction and finger extension strength. And then from there, they use various biomarkers as required to resolve uncertainty to eventually kind of provide a classification of predicted potential for upper extremity recovery early after stroke. And so for the PREP1 and PREP2 algorithms, they're looking at neurophysiological measures such as TMS of the distal upper extremity. And they're also looking at integrity measures of the corticospinal tract using imaging. And again, following the algorithm, patients are either predicted to have excellent, good, limited, or poor recovery. And both of these models, I mean, PrEP2 is an iteration off of PrEP1 where they found they didn't need the imaging metric and they could just use an additional clinical measure, the NIH stroke scale, to predict upper extremity recovery potential. But both of these models have demonstrated pretty high predictive powers. The PrEP1 demonstrated a positive predictive power of 88%, and PrEP2 has made correct predictions for 75% of the patients in the original studies. And what's nice about these models and what the authors provide is that besides a description of, what does that category mean? If you are predicted to have good upper extremity potential, what does that mean? They provide a description, but they also outline potential areas of rehabilitation focused based on the predicted category that patients are going to be in. And so these authors have taken it a step further and have done implementation studies down in New Zealand, and early findings have been positive where in their most recent study, they found that when the PrEP algorithm was provided to therapists and patients, patients exhibited a shorter length of stay of about a week, which is huge if you know anything about our healthcare field. And therapists reported greater confidence in altering their therapy content when the PrEP algorithm was used. So again, this is just one study in a healthcare system that is very different than ours, and other implementation studies involving the PrEP algorithm are ongoing. And so I'm looking forward to hearing what those results are. So now I'm going to switch to walking impairment and recovery, which is really the main focus of what I do in my lab. And while the corticospinal tract is necessary for fine movements of the hands, locomotion and motor function of the legs is less dependent on the CST. So few studies have examined changes in white matter integrity or connectivity in lower extremity motor function and gait. And those that have, regarding extent of lesion CST overlap, there's been mixed results. That has been associated with walking recovery in some studies and other it hasn't. Secondary motor tract integrity has also been associated with walking impairment and recovery, specifically integrity of the cortico-reticulospinal tract and cerebrospinal tract. And again, in our lab, we showed that cortical disconnection of the ipsilesional primary motor cortex was an independent predictor of walking speed in chronic stroke. And then on the right here, we've got some data that hasn't been published yet, but again, just showing that when we look at FA in the corticospinal tract and red nucleus, we found it associated with both leg strength and walking speed. And then we took it a little step further, and instead of looking at gross strength measures, we decided to look at measures of coordination. And so we have some foot tapping measures, both single foot and bilateral. And we did find that connectivity between several cortical subcortical regions was also associated with foot tapping. So current walking prediction models are listed here. And again, research to date has shown that recovery of independent walking is associated with several factors, including acute lower limb weakness, trunk control, age, severity of stroke, etc. But only one study attempted to combine both clinical and neurological predictors, and that's the study, the TWIST study by Smith and colleagues. So here again is just kind of an overview of the TWIST algorithm. Again, the authors started utilizing a simple clinical measure as their starting point. So in this case, it was the trunk control test, which is just a 4-item test that assesses static and dynamic trunk control. They also investigated TMS and MRI, and looked at associations with these biomarkers and their ability to predict independent walking using the functional ambulation category. Neurophysiological and neuroimaging measures did not predict independent walking, however, after stroke. So this algorithm really only uses 2 simple clinical measures, the trunk control test and hip extension strength. So how can we improve upon prior work though? Fortunately, a few years back, some of the leading stroke rehabilitation researchers came together and they provided a consensus statement regarding the evidence for stroke recovery biomarkers that are helpful in outcome prediction and for identifying subgroups for stratification to be used in clinical trials. And what you see here is for motor recovery, the available evidence to date shows that integrity of the corticospinal tract as well as TMS measures at the upper extremity are ready for use as biomarkers for stroke recovery. And what you see on the right is, some promising markers, but these need more research before they can be recommended for use. The authors also provided recommendations for cognition and language studies as well, in case you're interested. Additionally, they also published a paper outlining some key themes for future research and collaboration. And I think this was a great thing that they did, because it's, you know, here are some main areas that we would like researchers to focus on to advance the field. And so one, they outlined that there needs to be an improved understanding of the natural history of recovery and stratification in trials. So we need more repeat longitudinal measurements after stroke, so we can really see what happens over time. We don't just need immediately after and then 6 months down the road. We really need to follow the natural course of recovery. And we need better patient stratification in clinical trials, because if utilized, trials of new treatments would have better success potentially identifying a true treatment effect, instead of maybe just applying this approach to anyone with a stroke. Two, there needs to be a better understanding of the neurobiology of spontaneous and treatment-induced recovery. We've got a lot of great basic science research here that has really outlined a lot of the cellular and molecular events post-stroke, but more work in humans is needed. And this can help us identify biological targets and provide basis for novel interventions in people with stroke. Three, we need characterizing of different stroke recovery phenotypes, responders versus non-responders. You know, are there underlying group differences between these two? Four, we need development of a network of clinical centers of excellence in stroke recovery. We've got a few of these in our country, but we need more, where clinicians utilize evidence-based practice and research is embedded. And five, they talked about a radical new aim, which in human subjects research a lot in stroke, we sometimes can constrain ourselves by thinking, oh, well, is this really feasible in our healthcare system? Well, maybe we don't need to do that because the likelihood of it being implemented is small. And what the authors said is that, well, we really need to know what is possible in terms of neuronal and functional recovery first, and we don't need to be constrained by our healthcare environment. So despite improvements in the medical management of acute stroke, large amounts of patients still suffer from long-lasting deficits across multiple domains. Thus, there's a strong need for improvement in and application of neurorehabilitation interventions. We need new treatments. More than likely, there'll be combinatorial approaches, and we need individualized treatment strategies to maximize therapeutic effects. Such insight will also help us address unexplained variability in recovery, especially in patients with more severe motor impairment. So the goal is to be able to provide prediction models for selecting optimal treatment strategies for individual patients based not only on their clinical presentation, like acutely after stroke, but also on their individual neural network state, maybe their growth factor levels and other predictive markers post-stroke. And lastly, understanding mechanisms of motor recovery and recovery potential can help guide therapeutic modulation of neural networks and growth factors associated with recovery. We do know exercise at high intensity increases neurotrophic factors such as BDNF and VEGF levels. It also enhances functional connectivity. And this is going to be very important for up and rising research approaches that are really looking at non-invasive brain stimulation and brain-computer interface approaches. And so lastly, you know, some research on the horizon involves my COBRA project, which is looking at biomarkers of independent walking post-stroke. It is a longitudinal observational study looking at 6 different time points within the first 6 months of stroke. And I'm using a novel combination of acute clinical measures, neuroimaging, and physiological biomarkers, and examining their relationship with independent walking recovery. And I'd just like to thank my COBRA mentors, my lab team, and other collaborators. Thank you.
That was great, Denise. Thanks so much. So I'm going to open this up for questions and answers. So if you would like to place your question in the chat, you can do that, or you can raise it verbally.
Jessica has a question.
Hi, great talk. My question sort of intersects with your talk with Chris's talk, and I'm just curious, does this intense exercise still produce tangible results in the context of things like Alzheimer's or other, you know, disease states within the cardiovascular system? Like, do you still see like a good improvement with intense exercise?
So that's a very good question. And I don't know if Chris might know a little bit more because I tend to focus more on the motor aspect than the cognitive. I am looking at some cognitive measures in my COBRA study, so we will be looking at that. But so, I mean, my thought would be yes from what I know, but I'm not as familiar with the research. So again, I don't know if Chris has anything to add here. And Chris might not.
I can jump in. Yeah, there's some evidence that high intensity interval training is effective in different clinical groups. Some folks have used it in heart failure, standard cardiac rehab, as opposed to HIIT training. And there's some evidence. I think the getting people to do it is the question. You can do it for 3 months in a cardiac rehab setting, but then getting them to do it at home. So I think there's some implementation potential questions there, but there's some evidence that it's effective.
I mean, it's a big mode of treatment in terms of motor recovery. We've just had clinical practice guideline paper come out this year that really stresses using high intensity gait training for people with stroke, spinal cord injury, traumatic brain injury. So it is a evidence-based modality that definitely has shown many gains. And so, but Dave is right. They do great when they're with us, but when they get back home, it's a little bit hard to sustain.
So there's a question in the chat from Richard Riker. Do you think there's a role for acute pharmacologic interventions like neurostimulants within the first few days after stroke, after acute stroke in this area?
That's a very good question. And again, part of my project is going to be looking at a couple of different blood biomarkers early after stroke and their relationship with specifically walking recovery and how they change over time. And again, I think this is where if we see low levels of certain markers as associated with worse outcome, then if we are able to detect that early after stroke and then can provide whether it's pharmacologic or other types of interventions to increase those levels, that definitely could be a potential treatment point. But more research definitely needs to be done there.
Yeah, I could see, since I know a lot about your study, obviously, I could see, so you're going to have a biorepository of these samples, and it could be made available for people to study circulating biomarkers of interest. Or proteomic panels or whatever, just to try to generate hypotheses about the early factors, at least that might be neuronal damage markers. There's some nice panels for that too, in addition to what you had planned. So I'm just like thinking out loud.
Oh yeah, because we're trying to catch it within 3 days, at 1 week, and at 3 months after stroke. So we'll have hopefully, some good samples.
So this kind of, Dave and I were actually in the chat. I was thinking about the cross connection of all these talks, and maybe the speakers might want to, put their videos on and maybe have a discussion. We have a few minutes left, 4 minutes left, to think about how their work connects with each other. I know we didn't warn you on this in advance, so don't feel compelled, but I was kind of seeing connections across the presentations that I thought were really interesting. So any takers? It's a challenge.
Well, I'm sold on zebrafish being really cool now, so.
Well, I feel like my goal has been accomplished. I, for some reason, can't turn on my video. Otherwise, I would, for the sake of, attempting human interaction. Yeah, I mean, I don't know. I guess I feel like, this comes back to like, we should all be really focused on taking care of our cardiovascular systems if we want to live, long, healthy lives where our brains function. Yeah, all of our energy seems to go into really fancy ways to treat it once it's broken. Not that we don't need that too, but like, it seems like there maybe should be a balance earlier. I don't know.
Well, as an epidemiologist, I can tell you primordial prevention. We had a grant reviewer recently say that hypertension isn't a disease because we were talking about trying to prevent hypertension.
Wow.
It's like, they're like stuck on, you know, the heart disease or the stroke. And so, you know, this is we need a lot more research and kind of awareness that we need to do primordial prevention in utero and childhood and young adulthood, especially.
I thought I'd also mention too, because I don't think there's a lot of crosstalk between environmental health and, you know, people who are studying human disease in a lot of other contexts, that, you know, there's, you know, a lot of evidence that there are specific chemicals out there that, for instance, per and polyfluoral alkyl substances that can produce dyslipidemia. And so I think sometimes those things get missed as well, or how they can synergize with things like high sugar diets and sort of compound the adverse effects that we're seeing.
Yeah, Jessica, I was keen on that when you mentioned it in your talk, because so I do observational epidemiology with large cohorts, and we do have, you know, rich phenotyping data on people who are aging in their communities, and we have biorepositories for these cohorts at our lab at the University of Vermont. We have about 4.5 million samples or something like that in our biorepository from tens of thousands of people. And there have been investigations now and then of people interested in studying these chemicals. I've been working a lot with Ka-hee at Columbia, who's studying metals, trace elements, but anything that can be measured in stored samples. You know, if you have ideas or your collaborators have ideas, we have rich, you know, clinical data on these people. So connecting those things you're studying in the fish to our human populations is possible too.
Yeah, I mean, Jessica, that's a great point, just because, you know, here I am, someone who works in, gait physical activity, and we're always like, be physically active, go, go, go. But usually that's outside. So I've always actually wondered, well, geez, like in these very polluted areas, like really, how good is that? Like they're basically asking people to go outside, increase their respiration rate, breathe in, breathe in, breathe in, breathe in. And I've always wondered, now, yes, the act of exercising is good for your body, but over time, what are those pollutants in the air like doing? And I don't think we have really a great understanding of that. We just say exercise, be physically active, without taking the environment as much into account. So,
well, I'm also still the like, go with the exercise, but I'm wondering, I feel like as we think more about, personal protection in the context of disease prevention, that we might also think about that in the context of environmental pollution too. And so, certainly it's a possibility, for people just to be more aware of their ozone level, or, there are a lot of resources that people have put together so you can have a better real-time monitoring of your environment, and then maybe balance that. Like maybe you wear some sort of sports mask on days where there's high pollution and other days you don't.
All right, thanks.
I just want to say, Mary, there's a great guy at Brown, Kurt Pinnell, who does a lot of great metabolomics, who I think might be interested in those samples. So I'll follow up with you.
Oh, absolutely. We have metabolomics data already as well in a lot of our studies. This is great. I mean, this is the point of this meeting, right?
Yeah, so I'm just gonna wrap up for us since we're at time. I want to reiterate what Mary said at the beginning, that it was really interesting to get together and put the session together and see, how much work was being done in this area by the IDEA institutes across the Northeast region. And I think you got a flavor for that, for the diversity of approaches, the diversity of research topics and so forth that were presented today. So I want to thank Mary for helping put this together. It was nice to work together. I'd like to thank all the speakers who did a great job with their presentations. And I'd like to thank all the audience members who attended. I'd like to hopefully wish you a great rest of your summer. Enjoy the rest of the NERIC meeting that's left. Not much, but thanks again for attending.